In our second case, we're going to take a look at cervical and scapular pain following whiplash. So the physical therapy diagnosis that we saw was whiplash-associated disorder. And you can see the pain was located primarily in the scapular region with some neck pain as well. The patient also complained of headaches. She was 28 years old and about 6 weeks ago was involved in a motor vehicle accident. So the patient presented to the clinic with bilateral suboccipital region, posterior neck, and medial scapular border pain, right side greater than left, from an MVA 6 weeks ago. Patient was rear-ended while looking to her left by a car moving 25 miles per hour. Pain was worse than with sitting, excessive movement, lifting, and sleeping. Pain was decreased with heat, meds, and massage. However, she noted that too intense massage would increase her symptoms as well. The patient reported a similar injury with a motor vehicle accident 4 or 5 years ago and trialed PT, however, kept getting worse. So she withdrew from physical therapy and tried to recover on her own, however, never fully recovered. Patient is a bank teller and stands all day at work. She is a 2-year-old and frequently has to lift her. Patient has not been able to exercise for the last 6 months since recovering from breast reduction surgery. X-rays are negative. She has a history of depression, high cholesterol, and an allergy to adhesives. So in our objective exam, I think it's important to note that this was performed over the first couple sessions. Not all of this was done day one. The reason being is that people after whiplash often are super sensitive with over assessment and too much prodding. So typically on day one, what I'll focus on is get a sense for how the patient's moving, what sort of apprehension they have. As long as things look good neurologically, I probably won't do a ton of intense strength testing or special testing. But we want to make sure the patient is safe first and get a sense for where they're at, and then we'll kind of go from there. Now, over the first few sessions, what the information we did get, I've put in these couple slides. So she exhibited forward head posture, bilateral scapula downwardly rotated and protracted, mini Dowager's hump at the CT junction, and mild thoracic kyphosis. Cervical spine range of motion, flexion 70%, extension 60%, rotation 70% left, 80% right, side bend 50% left, 20% right. Thoracic spine range of motion, seated active range of motion with the arms overhead. We saw a loss of motion bilaterally with greater restriction to the right. We did the combined shoulder flexion, abduction, external rotation, range of motion, and functional on the left, non-painful, and dysfunctional painful on the right. With combined shoulder extension, adduction, and internal rotation or range of motion, we have functional non-painful on the left, dysfunctional painful on the right. So you can see overall there's a greater loss of motion and greater pain on the right side. However, there are some restrictions on the left as well. Elbow, hand, range of motion within normal limits. But when we did get to strength testing, you can see that there was some general weakness throughout. However, no specific myotomal deficit. A lot of it seemed like it was painful guarding, and then also general weakness from not being active for the last 6 months. Negative neurovascular screen with the 5Ds and 3Ms. When we got to joint mobility assessment, C4 through 7 were restricted side glides bilaterally and very tender as well. Hypomobility was noted with OA flexion and guarding with PA of C7 to T6, and then restricted first rib mobility on the right inferiorly. Normal dermatomes and reflexes. The ligamentous testing was negative. And with our movement analysis, what we saw was that most motion occurred in the upper cervical spine with greatest restriction in the CT junction. And there was painful kind of wincing at end range of all motions. So this patient very obviously falls into our whiplash-associated disorders category for treatment. And what the research has shown is our number one tool for these patients, especially early on, is education. So when we get through our exam, what we're going to focus on is, again, get a sense for how the patient's moving, what their thoughts are about their injury, and a baseline for some of that motion. Don't worry too much about strength or special testing outside of the safeties, but we want to get quickly to the point of education. And some of the main factors we want to point out are 85% of patients recover within 6 months. There is an end to this. Odds are in their favor for sure. Early return to normal, non-provocative pre-accident activities is important. So we want our patients to try and become active. We don't want to tell them to go out and run a marathon or anything. We want them to try and start getting back to their normal lifestyle in a graded manner, and listen to their bodies as far as if they're doing too much. And there are different ways that we can handle this, which I'll go over in a little bit. There's a good prognosis, and full recovery frequently occurs with physical therapy after a whiplash. We want to divert their attention from their condition and focus instead on just increasing the overall activities, encouraging a positive mindset, looking towards positive outcomes. We want to address any fear of movement and any other biopsychosocial factors. And then definitely do some pain science education. Really teach them about, hurt versus harm and how the body will normally respond to healing abilities, and they do not have to get stuck in that painful state. Our second intervention is therapeutic exercise, and that's pretty vague. And I think what you want to focus instead on is general conditioning and range of motion or mobility type exercises. So, for example, starting off with some cardiovascular exercises. Now, if the patient's coming in with whiplash, odds are they're dealing with some form of neck pain or headache. What we can do is have the patient do a lower body sort of cardio, such as going for a walk or riding a recumbent bike. I'm just trying to get their heart rate up there a little bit without aggravating any of their symptoms. As they progress and feel better, we can start incorporating the arm bike as well, or something a little more dynamic like elliptical, but you want to start non-threatening and work your way along without making the system angry. We want to do some general strengthening and conditioning exercises for the full body. Again, patient might come in with neck pain. You might have them doing leg curls on a machine. You might have them doing squats on the shuttle. And you're not really focused on repetitions here. It's more so just kind of get them moving. And when they start getting a little bit tired, or if they start complaining of a little bit discomfort, you move on to something else. You can break that up with some different stretches or active mobility exercises as well. We want a graded progression in spinal mobility. So their homework might include some exercises just working on cervical range of motion in a pain-free range. Or maybe you're starting down in the lumbar and thoracic region. With the connection of the nervous system from head to toe, movement of the spine in any place can have benefits higher up as well. So you might have them doing lower trunk rotation or sideline thoracic rotation, or just, again, cervical range of motion in a pain-free range. Want to gradually increase their activity, and that's not just exercise, but also what they're doing outside the home. So if they like to do yard work, you want to just start gradually working them towards that. And then as their threat level lowers and activity tolerance increases, we can start getting focused on more specific impairments that are remaining. And they might be ones that were there prior to the car accident, but initially were too sensitive to address and it wasn't as important. But as things calm down and some remaining deficits remain, we can address those specifically. And again, we definitely want to incorporate therapeutic neuroscience education for these patients. And I think just a general mindset for this is just use non-threatening words and really, again, keep a positive focus with your language and your education of the prognosis of care. So an example treatment is starting off with a little bit of manual therapy simultaneously with some education. So you might be educating the patient on the prognosis, recovery, gradual return to prior level of function, all while doing some light thoracic mobilization for pain relief and using maybe I-stim or SAS-stim or whatever method of soft tissue you want to do along some of the parascapular muscles or the suboccipital muscles, keeping things, again, non-threatening, but all while doing that multitask. Use that time to educate your patient. And then we'll switch over to some therapeutic exercise, and um, you might have doing a little bit of cardiovascular on the recumbent bike, the UBE. Again, you get them on the total gym or the shuttle, doing some squats. You can see I didn't put a specific number of repetitions. We focused more on time for each of these. Then we got to doing some valve slides, cable rows, pulleys, body underhead on the fitter discs. That's where you're twisting your hips while keeping a stable head. Hamstring curls, quad extensions, cervical range of motion. So you see a lot of mobility type exercise, and I'd like to alternate. So do a little cardio as a base, then do an exercise that kind of gets them moving, then something a little bit strengthening. And we're not going super heavy on any of these. It's more focus on get them moving and start activating and getting blood flow to the muscles. I think our big take-home points for a case like this with whiplash is, number one, education is one of the most important aspects in our treatment. You should be doing that day one and just stay as positive as you can. Tell them how great patients typically do recovering from whiplash. When their threat level is high, you want to use aerobic conditioning to increase activity tolerance. Really, that goal is get them, maybe if you can, heart rate up a little bit, sweating a little bit. Just try and get them more active, and you might need to start with something with the legs, even though they're in for the neck. Don't be afraid to multitask. So you can perform education while doing things like exercise or manual therapy, some modalities if you're wanting to use that. But absolutely keep up with that education. And then lastly, if the patient is too guarded or fearful in one region, exercise distant regions to positively affect the nervous system. Same sort of mindset with something like CRPS. Patient has a really painful foot and afraid to move that at all. Work out those arms. Get them on the arm bike. Start moving the scapular muscles, because you can get a heart rate pretty quickly up there, or work up a sweat a little bit doing some stuff with the upper body, and that's still going to have a positive impact the on the affected region in the lower extremity. So really, I think the main things to focus on are education, aerobic exercise, be efficient with your time, and get your patient moving gradually.